Good evening, everyone. My name is Deborah Pora, and I'm a nurse practitioner and project manager at VCU in the Pauley Heart Center. I'm delighted to welcome you to this month's installment of our Cardiovascular Medicine for Primary Care Providers CME series. If this is the first time that you guys are joining us, this series takes place on the third Wednesday of each month through 2025. If you've registered once, that's the only time that you need to register. As a quick reminder for the CME credit, please text the code 36733 to 804-625-4041 within the next 48 hours and complete your course evaluation within the 30 days. You can find more information at vcu.cloud-cme.com, or you can email me with any questions at deborah.pora@vcuhealth.org. I'll also drop this information in the chat for easy access. Tonight, I'm honored to introduce not just one, but two exceptional leaders in the field of hypertrophic cardiomyopathy and cardiomyopathies, Luke Balmer, who's a nurse practitioner at VCU in the Hypertrophic Cardiomyopathy Clinic, and Dr. Mohammed Makkiya, who is our medical director at VCU HCM Specialty Program. Together, they represent a forefront of clinical expertise in hypertrophic cardiomyopathy, serving as a statewide resource for complex cardiomyopathy care. Their dedication to advancing diagnosis, treatment, and patient education has made the VCU HCM program a beacon of excellence, not just within the institution, but across Virginia. Tonight's talk will cover the range of important cardiomyopathies, including hypertrophic cardiomyopathy, cardiosarcoidosis, and amyloidosis, conditions that require a nuance of teams and a multidisciplinary collaboration. We are truly in for a high-packed, clinical relevant session with insights that will help strengthen everyone's practice. Please join me in welcoming Luke Balmer and Dr. Mohammed Makkiya. Thank you.
Thank you for the kind introduction, Deb. Can you hear me okay?
Yes, I can.
All right. Thank you again for that introduction. Again, my name is Luke Balmer, one of the cardiology nurse practitioners that works here in the Hypertrophic Cardiomyopathy Clinic with Dr. Makkiya, along with Deborah, who works with us in the clinic. We're going to be talking with you guys a bit today about these cardiomyopathies, disease processes, and so forth. We want to let you know, here at VCU, the Hypertrophic Cardiomyopathy Clinic, it's a collaborative team involving multiple subspecialties, including electrophysiology, cardiothoracic surgery, structural cardiology, and imagers. As time goes on, we find more and more people, our patients, affected by this disease. And so there's just a growing need, certainly, in cardiology, and to make an awareness across the primary care setting and everywhere about this. So a little bit about the learning objectives there. We'll be going over some of those things, including early detection and screening for these cardiomyopathies, identifying the role of non-invasive imaging in diagnosis and prognosis, identifying the role of genetics and importance of family screening, and lastly, medical management of some of these cardiomyopathies. And again, as Deborah said, don't forget to text that code for the CME credit at the end of the presentation as well. No disclosures for me. So I'll delve a little bit here into the types of hypertrophic cardiomyopathy. Generally speaking, we break these into two categories: the obstructive and non-obstructive hypertrophic cardiomyopathy. And what that means is obstructive means there's a blood flow obstruction across the LV outflow tract where the blood leaves the heart. I'm going to have a better picture of it later. I know these images are kind of scrunched together a little bit. So I'll have a better picture a little later, but ultimately it's that obstruction of the blood flow across the LV outflow tract, non-obstructive being the opposite. There's no obstruction there in the left ventricular outflow tract. I'll briefly mention these, some of these morphologies that we see. Again, I won't get too deep into it, but a lot of these just have to do with where the thickness is in the heart. So apical at the apex of the heart, and for example, sigmoid being closer to where that LV outflow tract is, and that's closer to causing an obstruction because of where it's located. This is something definitely to pay attention to. A lot of times, you know, in the primary care setting, you all may be the first providers that come into contact with these patients. So these are some of the common symptoms or signs that you may come into contact with when the patients come to see you. It can be difficult with hypertrophic cardiomyopathy to tease out whether it's from a thick heart cardiomyopathy versus arrhythmias, ischemia, even heart failure symptoms, because a lot of them can cross-relate. So it's not a one size fits all in that respect. So it can make it challenging. So we talk about initial presentation. Somebody comes to your clinic, they're complaining of chest pain, they're complaining of shortness of breath, palpitations. Many of you will have access to an EKG, and so it's important just to kind of know the basic things to look for when you may be suspecting hypertrophic cardiomyopathy. So if somebody comes to your clinic and you see an EKG that shows this, the increased QRS voltage there, definitely something to be leery of when you're screening them. This is another EKG example showing these deep, narrow Q waves. And in hypertrophic cardiomyopathy, you can see these in the inferior and lateral leads of the EKG. And Q waves can indicate ischemia as well, but this should be in the back of your mind as a possibility for hypertrophic cardiomyopathy. And another EKG example, this can be a scary one to see, especially in the primary care setting or really anywhere. A patient presents to the ED and this is what their EKG looks like. It can make some people probably jump around and worry about ischemia as a cause. But when the T waves are this deeply, incredibly deeply inverted, apical variant of hypertrophic cardiomyopathy should be in the back of the provider's mind. And they are incredibly abnormal looking EKGs. So just something for you guys to be aware of if you're getting EKGs in the primary setting. So I'll delve a little bit here into the genetics of the disease. Hypertrophic cardiomyopathy is it's caused by mutations in the sarcomere genes. And so it can be difficult because the phenotypes, they can be modulated by other risk factors such as obesity, diabetes, hypertension, especially a long history of uncontrolled hypertension, aortic stenosis, amongst other things. So these kinds of comorbidities can make it difficult to tease this out. But ultimately, it's an autosomal dominant disorder, meaning that it's passed down from one parent to a child through the mutated gene. Now it's a disease of variable penetrance and variable expression. And what that means is that it's an unpredictable disease. We don't know how significant or aggressive the disease is going to be. And for one family member, for their offspring, they could have a less aggressive form of the disease or even no disease at all. This is why screening and gene testing is so incredibly important. So we get this gene testing, and I have listed here some of the more common pathogenic gene mutations, including MYH7 and MYBPC3. We can often get results from gene testing that show variants of uncertain significance or even negative gene testing. And that doesn't mean that they don't have hypertrophic cardiomyopathy. What it means is that we may just not know about that gene yet. But nevertheless, gene testing is vital for family screening. And in general, our recommendations, and this may be helpful for you all to know in the primary care setting, because you may see some of these patients who say, oh, my mother or father has hypertrophic cardiomyopathy. They should be screened at least every 3 to 5 years, first-line family members. And that's what that means is an EKG and an echocardiogram. They should be seen by a cardiologist or cardiology provider and have that screening. And again, every 3 to 5 years. It can be more frequent for children, teenagers, and competitive athletes, but that's our general rule of thumb, every 3 to 5 years. So the why, we talked about it a bit. Arguably, one of the most important aspects is sudden cardiac death prevention. It's estimated that roughly 1 in every 200 people have HCM. So a large percentage of patients are undiagnosed, and a lot of that has to do with certain countries, territories, not having adequate resources and lack of access to healthcare. So there's many people that are out there that are undiagnosed. But going back to the sudden cardiac death prevention, it's still the leading cause of sudden cardiac death in young athletes, disproportionately affects Black athletes, and is more frequently linked to competitive sports. And obviously, it doesn't just impact the athletes, but certainly gets more publicity in that regard. But again, things to keep our eye out on, and these are very important, one of the cornerstones of our clinic. Going to go a little bit into testing, diagnostic studies here. So the mainstay test, echocardiogram. So if there's someone having symptoms, especially they have an abnormal EKG, or we're doing some of the family screening, it's helpful to have this echo for more information. And from a primary perspective, it can be helpful for us to have an echocardiogram before they come to see us. So if there's concern, or they have family history, or they have an abnormal EKG, having that echo done before they see us, again, it can be helpful. So, what we're looking for is that septal thickness. How thick is their septum? Do they have that LV outflow tract, that left ventricular outflow tract obstruction? We can look at rest. We can have them bear down, like a Valsalva maneuver, to see if there's one that's inducible. We can even send them for an exercise echo to see if they're having that obstruction with provocation with exercise. And if once they see us, there's concern for HCM on their echocardiogram, we'll more than likely move towards a cardiac MRI, which gets more precise measurements of the left ventricle and septal thickness. And we use the gadolinium enhancement and assesses the myocardial viability, assesses fibrosis. And this can be helpful when we're talking about that risk screening for sudden cardiac death, looking for excessive scar, because a lot of these hypertrophic cardiomyopathy patients can develop scarring in the heart, which can lead to malignant arrhythmias. And that's the next part that I wanted to mention, ambulatory monitors, specifically extended ambulatory monitors. And we're looking for those arrhythmias, such as ventricular tachycardia, as well as atrial fibrillation is a very common one with hypertrophic cardiomyopathy patients. Just like with the echo, if you guys see these patients in clinic, and especially if they have symptoms and there's concern for hypertrophic cardiomyopathy, it can be helpful to have an extended Holter monitor or an MCOT before they come to see us to see if they're having any of these concerning arrhythmias. And lastly, the gene testing again is helpful for the reasons aforementioned. Diagnostic criteria for hypertrophic cardiomyopathy. So it's left ventricular hypertrophy in the absence of another cardiac or systemic disease that can cause hypertrophy. And specifically, the maximal end diastolic wall thickness of 1.5 centimeters anywhere in the left ventricle. And again, I mentioned before, there can be a lot of other factors that can modulate this, uncontrolled blood pressures, things like that. But generally speaking, this is the diagnostic criteria. And specifically for obstruction that we're looking for, would indicate an outflow tract obstruction of at least 30 millimeters of mercury, either at rest, or 50 millimeters of mercury on provocation, so like with Valsalva or exercise. This is the better picture I was talking about. You can see where there's the thickened septum there, and basically what's happening, there's increased blood flow going through that LV outflow tract, and that increased velocity, the blood flow, is pulling that mitral valve, that anterior mitral valve leaflet, and causing an obstruction. And what we call that systolic anterior motion of the mitral valve, SAM, you may have heard that acronym for that, and that's what causes the obstruction. Differential diagnoses for left ventricular hypertrophy, obviously the first on there, hypertrophic cardiomyopathy, but it's important for us, when we see them in clinic, to consider other things such as hypertensive heart disease, which is a very common one we see, athlete's heart, amyloidosis, which Dr. Makkiya will be talking about shortly, aortic valve stenosis, as well as storage and metabolic diseases such as Pompe, Fabry's disease, Danon. So again, it can take further family screening, diagnostic testing, interviewing the patient, things like that, to help us determine what's exactly going on. These are some complications of the disease, and again, I'm not going to get too far in the weeds in this, but I want to show this graph because it is that important to try and catch this disease as early as possible. As you can see here, numerous things that can lead to detrimental impacts for the patients. So specifically, atrial fibrillation and stroke. So for hypertrophic cardiomyopathy, due to the increased risk of thromboembolism, it's indicated for them to be on anticoagulation regardless of their CHA2DS2-VASc score. So you don't calculate it like you would for somebody without hypertrophic cardiomyopathy. So we co-manage a lot of these patients with electrophysiology for their AFib, but also if there's concern for ventricular arrhythmias. So they see them for antiarrhythmic medications, ablations, certain things like that we co-manage. And we also can co-manage these patients with heart failure when they develop things like a significant diastolic heart failure, as well as the end-stage heart failure, which can occur in late-stage hypertrophic cardiomyopathy, in which case they need to see our advanced heart failure team and start talking about advanced therapies. There's the progressive obstructive hypertrophic cardiomyopathy, in which case we talk about certain treatments for that, which we'll talk about later. And then one of the most important ones, which I've mentioned, is sudden cardiac death. And then we talk about a possible defibrillator if we feel they're a candidate and would benefit from it. So here's a bit on risk stratifying for sudden cardiac death. Again, this is one of the most important facets of our clinic, risk stratifying them and preventing sudden cardiac death. So this is a picture here, and basically it's the AHA-ACC guidelines indicating when somebody could benefit from a defibrillator. So family history of sudden cardiac death, essentially meaning a first-line family member before the age of 40 dying suddenly. And this can be a bit misconstrued with patients because they may say, oh, my father had a heart attack at 30-something years old. That could very likely be sudden cardiac death because a lot of patients and families, they're not aware of that difference between a heart attack and sudden cardiac death. Other things here: massive hypertrophy, greater than 3 centimeter septal thickness, unexplained syncope, that can be a concern, as well as a low ejection fraction. We have many conversations with people if they have ventricular tachycardia, non-sustained ventricular tachycardia on their monitoring, and or extensive enhancement or scarring on their MRI. These are things that we have to look at closely with these patients and have shared decision-making with them. And that leads into my next slide. It's important to discuss with these patients the benefits and risks of getting a defibrillator if we feel that they're increased risk. We want to tell them, there's the risk of infection, bleeding, et cetera, during the procedure. But at the end of the day, if we feel that they're at increased risk and they would benefit, we explain it to them, it's an insurance policy. The goal is to protect you, to shock you out of this sustained ventricular arrhythmia that could ultimately lead to a sudden cardiac death. So that's our goal with these patients. I'm going to go a little bit into treatment. So the treatment for non-obstructive hypertrophic cardiomyopathy, there is no effective medical treatment for non-obstructive HCM. And the goal is to aid in heart failure symptoms and mitigate their risk factors. And a lot of that can start in the primary care setting. Blood pressure medications, compliance with CPAP, weight loss, heart healthy diet, exercise, all of these can help slow the progression of the disease. Obviously, co-management with heart failure, especially if the diastolic heart failure, so using non-dihydropyridine calcium channel blockers, if need be, diuretics, and things of that nature. And certainly if they have a reduced ejection fraction, co-management with heart failure. Treatment for obstructive hypertrophic cardiomyopathy. So for first line, we use beta blockers as well as non-dihydropyridine calcium channel blockers such as diltiazem and verapamil. And the goal is to max out these medications as much as the patients can tolerate in an attempt to alleviate the left ventricular outflow tract obstruction. What you're trying to do is slow their heart rate, reduce the LV contractility, and improve their symptoms. Now, sometimes patients don't do well, or you get them maxed out on therapy and they still feel bad. They're feeling the shortness of breath, fatigue, chest pain. So then you talk about these second line therapies, disopyramide or cardiac myosin inhibitors. Disopyramide is an antiarrhythmic, so it's a medication where somebody would need to be like a drug load. They need to be admitted to start that medication. Slightly fallen out of favor in recent years for reasons I'll talk about soon, but it does have anticholinergic effects and things of that nature. So, but it is still an option for patients. And then the newest medication, medical therapy, cardiac myosin inhibitors, which I'll mention here very soon, a little bit more about that. But your patients may come to you in clinic and tell you that they saw this Camzyos or mavacamten on a commercial recently. Medications to avoid an obstructive hypertrophic cardiomyopathy. Number one, arguably, would be diuretics. These patients are preload dependent, and diuresing them excessively can exacerbate their left ventricular outflow tract obstruction. It can be difficult, right? Because a lot of these patients have resistant hypertension. And so you say, you know, this thiazide diuretic has been controlling this patient's blood pressure. They're doing well. You know, ideally they're not on it, but sometimes we don't have a choice. Other medications to avoid vasodilators such as nitrates, dihydropyridine calcium channel blockers such as amlodipine, nifedipine, as well as even ACEs and ARBs. That should not be first line for these patients. As well as avoiding, you know, we are in discussions with people who have these obstructive hypertrophic cardiomyopathy and need surgeries. So there's certain things you want to avoid. And the first line for hypotension and things like that during surgery, you want to give them fluid. And then if that doesn't work, you have to discuss different types of alpha adrenergic receptor agonists, things like that to again, you want to avoid that inotropic activity that can worsen the left ventricular outflow tract obstruction. In general, what we want you guys to take away from this is we want to maintain their preload, try and avoid diuretics if at all possible in these patients. A little bit more about treatment. And again, I'm not going to get too deep into this, but for patients that still have obstruction, despite you trying to do what you can with the beta blockers, calcium channel blockers, we talk with them about these options, myectomy and alcohol septal ablation. Now, myectomy is an open heart surgery where they go in and actually shave that septal tissue to improve the blood flow through the left ventricular outflow tract. It actually has one of the lowest operative mortality rates in comparison with other cardiac surgeries, but there are obviously still risks, and it's important to discuss that with them when we're having our shared decision making with these patients. Alcohol septal ablation, it's a less invasive approach, can be more suitable for maybe older patients that aren't a good candidate or higher risk for open heart surgery. It's done here by our structural heart team at VCU. We do these, and you basically travel up the heart with a catheter. You go through one of the septal perforator branches of the left anterior descending artery, and you inject alcohol, ethanol, into the tissue, shrinks the tissue, and it alleviates the obstruction. There's a slightly higher recurrence of the obstruction with doing this as opposed to the surgery, but again, it's what's best for the patient. And this also can have effects like complete heart blocks, a big one, sometimes needing a pacemaker, etc. So those are some of the options there. And one of the last things I want to mention here, the cardiac myosin inhibitors, which I hit on a bit. This is the newest novel medication for these obstructive HCM. Mavacamten came out as the only approved one by the FDA in 2022 thus far. It acts by inhibiting the actin-myosin cross bridges to reduce the contractility of the left ventricle. We have a long conversation with our patients about this in clinic because it requires very frequent testing, monitoring their ejection fraction. The biggest adverse side effect of the medication is systolic heart failure. And luckily, this has been reversible with pausing and stopping the medication. But it's just important to have that conversation. But we've had drastic improvement in patient symptoms, as well as seeing an improvement, an alleviation of the obstruction on their echocardiograms, as well as even improvement in their cardiac enzymes on this medication. So we do have a lot of patients on this medication now here at VCU with the Hypertrophic Cardiomyopathy Clinic, and it's helped them a lot. We go over the potential side effects with them. Sometimes they have palpitations, dizziness, fatigue, but usually these things subside. So for what it's worth, this is a great medication, and we have many patients on it. That is all for my portion. I appreciate you listening to what I have to say. And for now, I will turn it over to Dr. Makkiya.
Great talk, Luke. Let me share my screen, or you want to do it that way?
I can do it this way and click it for you if you're okay with that.
That's fine. Thanks. All right, guys. So the second part of the talk, I'm going to talk about infiltrative cardiomyopathy. So it's part of the spectrum that we see in hypertrophic cardiomyopathies, and Luke hinged on some of the differential diagnosis for that. And we have plenty. The major ones are cardiac amyloid, cardiac sarcoid, hemochromatosis, and the genetic Henderson-Fabry's disease. Less common ones, we have Danon disease, Pompe's, Friedreich ataxia, and so forth. These are less common. You don't often see in practice, but definitely you're gonna get across cardiac amyloid, cardiac sarcoid, probably hemochromatosis as you go there. Next. So I'm gonna start with cardiac amyloidosis next. This is a protein disease where a protein usually misfolds, doesn't fold right, and either it's going to be a plasma protein or a liver protein. It's assumed a different shape than it should be, and then it results in this abnormal protein that aggregates and deposits in various tissues of the body. Heart is one of them. Okay. If it happens to be plasma protein, it causes AL amyloidosis. If it happens to be liver protein, it causes ATTR amyloidosis. Next. So the types of cardiac amyloidosis, we have ATTR mainly, and the AL types responsible for 95% of cardiac amyloidosis or amyloidosis in general. AL amyloidosis is a plasma misfolded protein disorder resulting in the overproduction of this misfold protein. And it is a rare disease, but it's more aggressive form of amyloidosis, especially cardiac amyloidosis when it happens. ATTR amyloidosis is a misfolding protein in the liver called transthyretin protein, previously called prealbumin. Either it comes in two flavors, either a wild type, which is an acquired type, it just happens, acquired throughout life, or it can be genetic, hereditary, and an autosomal dominant fashion when that runs in the families. Next. So as all these cardiomyopathies, HCM is included, these are underdiagnosed cardiomyopathies, unfortunately. We are getting better at this with the awareness or spread of the awareness of these conditions and the availability of advanced cardiac imaging and centers to deal with that, like hypertrophic cardiomyopathy clinic that we run here at VCU, and we have an amyloid clinic, one of our colleagues, Khair Shah, who runs it. So we are much better at that. Recent study, like for example, showed 13, almost 15% of patients 60 years old or older who has diastolic heart failure, they actually have a diagnosis of amyloidosis, especially the ATTR one. The acquired type is more common in elderly men, where the carpal tunnel is bilateral. You have some spinal stenosis. The genetic ATTR that's common in the US, it involves two genes, or it can involve two genes. One of it is the valine genes, which you see that more in African American population. The second common is the T60A gene, which is you see more in patient of Irish descent. Next. So symptoms or red flags for people who have amyloidosis, especially cardiac amyloidosis, there is no specific signs or clinical symptoms. It's a variety of symptoms that can happen. It's overlap usually with other cardiac conditions or any types of cardiac condition that causes systolic or diastolic heart failure. But mainly it's basically these patients comes with heart failure symptoms or an arrhythmia symptoms, plus something extra, for example, kidney disease, intolerant to beta blocker and ACE inhibitors, to control their blood pressure and heart failure. They are orthostatic. They have a lot of orthostatic hypotension. They can have arrhythmia symptoms, palpitation, dizziness, sometimes even passing out. And amyloid, whether it's AL or ATTR, is commonly associated with neuropathies. So these people have carpal tunnel syndromes. A hint, if it's bilateral, not like unilateral, carpal tunnel syndrome can raise your suspicion in this why you have bilateral, back neuropathies, peripheral neuropathies. These people are usually anemic, especially in the AL type. But in general, there is no specific symptom. Hypertrophic cardiomyopathy, all the infiltrative cardiomyopathies, symptoms overlap. You cannot just base your diagnosis based on the symptoms. You should dig deeper. You should take a very good history, especially you guys are the front line in doing that. And then keep always that in your differential. Next. So I'm showing a picture which you can see maybe once or twice in your life. This can be very specific in AL amyloidosis, where we have microglossia, like the tongue is very enlarged. They call it strawberry tongue. You see that rarely. AL amyloidosis is the most common things that can cause it. And you have this periorbital or purpura, like somebody punch you, like when somebody punch you or you got hit in the eye, and you have it bilaterally. This can be seen and can be pathognomonic on your clinical exam and raise your suspicion for AL amyloidosis that you see with multiple myeloma. Okay, next. So EKG, so you start with an EKG, like anybody who like you are expecting cardiomyopathy. An EKG, the typical EKG in amyloidosis, where you have hypertrophic cardiomyopathy or LV hypertrophy, you don't see the changes that you see in your typical LVH hypertrophy, where you have high amplitude S or R waves. And matter of fact, you have the opposite. You have a very low voltage, as you see here, low amplitude QRS, which you should see it like that, like very high amplitude. That can be seen or very specific in cardiac amyloidosis, where you have LVH, but your EKG does not reflect that, does not reflect LVH. Having said that, it's also important that is not the case. You should not get this EKG all the time in these patients, okay? There are studies, that autopsy-proven studies for patients who have LVH with cardiac amyloidosis as the etiology, they have actually LVH signs on their EKG. So that's not always the case, but it should raise your suspicion. If you have somebody with LVH on their echo, you expect to see LVH signs on the EKG, rather than, but you see like low voltage signs with some Q wave anteriorly. That's very suggestive of amyloid. Next. So how we diagnose amyloid, we start with blood testing. We do cardiac enzymes, and these cardiac enzymes are not specific. Your high sensitivity troponin or pro-BNP. All of these cardiomyopathies can result in them getting up or getting higher than usual. So it's not specific for amyloid or hypertrophic cardiomyopathy per se, but it helps you in making a diagnosis of cardiomyopathy. Nothing else can make it elevated other than like cardiomyopathy. You should always test for AL amyloidosis and multiple myeloma. This is important, especially in treatment and how early you want to treat this and prognosis. So you need to check monoclonal proteins to rule out multiple myeloma. You should check the serum free light chain assay, the kappa lambda ratios, serum immunofixation. Serum and protein electrophoresis are insensitive to detect AL amyloidosis. I would stick with the ratio, like with the kappa free light chains ratio, kappa lambda, and the serum immunofixation, which shows a spike in M protein that you see in multiple myeloma. Plus these signs of AL amyloidosis, you make your diagnosis. And that's based on the blood work. Next. So like anything else, these cardiomyopathies, biopsy was the cornerstone of diagnosis in the past. However, since we have the advanced imaging now, where we are able to do detailed imaging using detailed techniques, I'm showing some here based on echo techniques that we do or echo softwares that we do that can help us in making the diagnosis, and we can make the diagnosis with high sensitivity and accuracy without doing myocardial biopsy. But typically what we see on echocardiogram, we see thickening, significant thickening of the heart muscles. You see some effusions, pericardial effusions in the lung, in the heart, pleural effusions, signs of diastolic heart failure. We do this technique, we call it strain, when we measure the strain of the heart muscle or the deformation of the heart muscle. And normally this should be all red, but when you see it is when it's lighter red, it means it's decreased. When it's decreased everywhere except in the middle where the apex of the heart is here, as you see in the pictures, that is also very sensitive and specific and suggestive of amyloidosis. So very easy, non-invasive techniques to make the diagnosis. These people have heart failure, and echo is a very, very good start in taking us to the right way. So if you have these patients, you see them, there is a mention of thickening of the heart muscle on the echo. They have heart failure symptoms. They have neuropathies. You do the EKG. There is low voltage. Keep high suspicion for heart amyloid and send them to get further evaluated. Next. Then comes the more sensitive or mostly the test that with a significant positive and negative predictive value, which means if it's positive, it is highly positive. It's called the technetium pyrophosphate scan, which is a nuclear scan. This is invented as in the 70s as a way of doing calcium score, like we are doing now in CT scan, but using a nuclear tracer in doing so. So this nuclear tracer has the affinity to bind to calcium. As you see here, the ribs and sternum lights up, which is calcified. And if it's lights up in the heart, we were thinking it lights up in coronary calcium and increased coronary disease. However, we didn't use it in that because the vessels are very small to really show that up. But later on, we find out that this tracer also had affinity to bind to ATTR protein in ATTR amyloidosis, a transthyretin protein in ATTR amyloidosis. So if you see that, usually when you give the tracer and you image, you wait about 2 hours. Very cheap, very easy studies. We bring the patient, we inject them with this tracer, inject their blood with this tracer, and we tell them go shop, go do like your chores, and come back in 2-3 hours, and we just take pictures. By that time, the tracer will distribute in the body. We take pictures of the heart, and it should be like that. You just have the tracer light up your sternum, your ribs. But in ATTR amyloidosis, the heart lights up like that. Very, very easy test, and you can use it. It's so quantitative. You can quantitate that basically, and gives us a ratio. There's some studies, although there is nothing 100% in life, but some studies says this has a 100% positive predictive value for ATTR amyloidosis. Very cheap and easy way, a non-invasive way to diagnose ATTR amyloidosis. Next. The other test, which is the cornerstone to differentiate these cardiomyopathies, I always start with that after an echocardiogram, because this can tells me or help me in making my differential diagnosis, or guide me toward this hypertrophy is mainly from amyloid versus genetic hypertrophy versus sarcoid. Is cardiac MRI. Cardiac MRI is very detailed. You take very detailed look at the heart. It's like watching a movie in Ultra HD or on IMAX versus echo watching movie on single definition. It also helps other than assessing the heart very well, dimensions, functions. It's a gold standard for that. It also tells us we can do tissue characterization when we give contrast, and we can look into scar in the heart muscle. And based on the pattern of the scar, every one of these cardiomyopathies can give us a distinct pattern or a unique pattern. You only see it in amyloid, you only see it in sarcoid, you only see it in ACM. And that can help us in guiding, making the diagnosis. Also, it helps us in prognostication. If we see a lot of scar, gives us an idea this disease is more advanced. So we have to be more aggressive, or we have to expect more complications from the disease, or we can do something to prevent these complications that you can have when you have an advanced disease, whether it's an amyloid, whether it's an ACM or sarcoid. So it has a very important prognostication role in that regard. But again, not everything is perfect. There are some overlap. Sometimes the patterns overlap, and it won't be very decisive. But a decisive test or decisive pattern is really help you make your diagnosis. Next. So biopsy is the gold standard. It's have 100% sensitivity, but remember, it's a procedure. There is 1% risk of complication related to the biopsy from perforation of the muscle that you're sampling, that leads to temple node. You have to do it by an experienced operator. What we see the TTR amyloid or the amyloid protein has an affinity for Congo red staining, produce this apple green birefringent picture that we see under the microscopy. Fat pod, I would stay away from fat pod biopsy. It has a lot of diagnostic limitation and negative fat pod. It's not very specific. It's not very sensitive. And a negative fat pod biopsy doesn't rule out amyloid. Next. So treatment, we have nowadays a lot of treatment options for amyloidosis. But before we go into that, we have to treat the heart failure. So these people can have systolic heart failure or diastolic heart failure, but mainly systolic heart failure. So you have to use your goal-directed medical therapies to treat the systolic heart failure, your ARBs, ARNIs, beta blockers. Sometimes we don't use the beta blocker in ATTR amyloid. It can worsen the symptoms. But in a general rule, use your ATT. Now, also making treatment of AL amyloid is very, very, very important. So you have to make the diagnosis. And earlier the treatment is better, because life expectancy can be 4 to 6 months in AL. If you develop AL amyloidosis in multiple myeloma, you can die within 6 months. The prognosis is very bad. However, you can really, really improve that prognosis to years if you start treatment early on, especially in AL amyloid. So make sure you have that always in your mind, even if you have patients with multiple myeloma, not necessarily all multiple myeloma patients or MGUS, they have AL amyloidosis. But if you start seeing heart failure on your echoes or symptoms, you do the EKG, you see some distinct features in the EKG, send them for an echo. And if the echo shows LVH or LV hypertrophy, keep that differential highly in your mind. We know nowadays also we have a lot of medications for ATTR amyloidosis. One of them is, or most famous one is tafamidis. They improve, they reduce mortality from the disease. They reduce symptoms of heart failure, even neuropathies and potential complications. Next. So the next disease is cardiac sarcoid. Next. Sarcoid is a multisystemic granulomatous disease of unknown etiology. The theory is caused by an immunological response to some antigen trigger in a genetically susceptible patients, resulting in these so-called non-caseating granulomas. On histology, affect patients from 20 to 60-year-olds, more in women. Lungs is the most common. It's again, it's an infiltrative, involved many organs, but lung is the most common disease 90% of the time. Cardiac involvement says 55% of the time, but we have a recent autopsy study. It's way higher. It is much higher than that, 25%. Next. Cardiac involvement, it can involve anywhere in the heart, but mostly it involves the left ventricle, especially the left ventricular flea wall and the septum, where the conduction system is, and it can involve the right ventricle, even the atria and papillary muscles. Next. What are the clinical manifestations? The first phase which is interesting about sarcoid, it is the electrical phase. You probably are not symptomatic, but you develop some form of arrhythmia. Symptoms, and you can develop symptoms related to that arrhythmias. For example, if it's atrial fibrillation, you present with palpitation, dizziness. Sometimes people pass out. Later on, as the disease advances, you develop heart failure symptoms. Next. So you start with an X-ray. The X-ray, you see in the white arrows, you see the very pathognomonic bilateral hilar lymphadenopathy and paratracheal lymphadenopathy. You see it in cardiac sarcoid lung involvement. CT is the cornerstone to make the diagnosis of lung sarcoid. And when the disease advances in the lung, you have the honeycombing, lung fibrosis, bullae, and atelectasis. Next. So on EKG, as I said, it can involve the septum. It commonly involves the septum where the conduction system is. So the most common EKG changes you see in cardiac sarcoid is heart blocks stemming from first degree to advanced degree heart block. That should raise your suspicion if you have a patient in their 40s or 50s and they have advanced degree heart block needing pacemaker. You should have that. You should think of sarcoid as a differential for etiology because you don't expect to have patients in their 40s or 50s to have sick sinus syndrome. You can have ventricular tachycardias. You can have supraventricular tachycardias from AFib, aflutter, etc. Next. So how we make the diagnosis? It's an imaging-based diagnosis based on the history, physical exam, EKG, and imaging. We start with an echocardiogram. Half of the time, the echo is going to be normal. As the disease becomes advanced, which we don't want it to do, we want to treat it before it becomes advanced, you start see the echo changes, which is dilated cardiomyopathy, systolic heart failure, and aneurysms, multiple aneurysms in segments of the heart. Then we do MRI. MRI, as I said, we see the same things that we see in advanced echo, but based on the pattern of the scarring in the heart, which usually involves the septum going into the right ventricle and anterior wall, that is more pattern that we see in sarcoid. And then we do PET scan where we use a tracer that has the affinity to bind to glucose. So what we do, we deprive the tissue from glucose, and if there is an active inflammation or edema, of course, the macrophages that are responsible for that, they feed on glucose, and you see glucose uptake or tracer uptake in that area that is active. The SPETs will help us in making the diagnosis, will help us to tell us if there is an active disease undergoing in the heart, and help to guide treatment uh, response. So when we start the immunosuppressions, typically we repeat the PET to see that area that used to be inflamed, is it gotten better? And we can also do quantitative analysis of that. Next. So biopsy is bad in sarcoid. Sensitivity is less than 25%. That's because of the focal nature of the disease. Not all areas of the heart is involved. So imagine basically when we do biopsy, we mostly we take chunks from the septum. But if that area is not involved, your biopsy is going to be falsely negative. We sometimes do some techniques, image-based biopsy. We pinpoint where the scar is and try to target it based on MRI or PET, or sometimes EP studies to do so. Still helps a little bit with the sensitivity, but not much. Next. So the treatment, as I said, for heart failure, if it's advanced, goal-directed medical therapy, as we do, like pacemaker for high-degree AV blocks, and immunosuppressive therapies for active cardiac sarcoid or lung sarcoid. Next. So the other infiltrative diseases, hemochromatosis. Next. This is iron overload. Cardiomyopathies arise due to abnormality in iron homeostasis and result in a lot of iron deposit anywhere in the body. Heart is one of the organs that involves. It comes in two flavors: primary, where is it a genetic disease, involve genes encoding proteins involved in iron metabolism like ferritin or hemosiderin, etc. Secondary hemochromatosis is an acquired form, usually from people who get chronic blood transfusion. These patients usually require chronic blood transfusion who have hemoglobinopathies like thalassemia is a major one, or MGUS. It involves multiple organs, mainly the liver, endocrine, and heart. Cardiac, when it's involved the heart, it can result in a higher mortality. Next. Diagnosis, you have to be, it's a use your history and physical exam. You can have heart failure symptoms on exam. You can have cirrhosis symptoms on hepatic involvement. You can have diabetes, erectile dysfunction. It can deposit in the joints and cause joint pain or arthritis. It can deposit in the skin, and you can have this kind of specific skin hyper pigmentation. We start with the blood work where we check ferritin levels, and it is significantly elevated. You check your liver function tests, you have elevated LFTs and signs of liver failure. Then we think about doing gene testing. And chest X-ray can show cardiomegaly congestion. EKG can show a variety of arrhythmias. Next. And we start with an echocardiogram. Echocardiogram, when the disease is advanced, can show either diastolic or systolic heart failure. It's mostly systolic heart failure and dilated cardiomyopathy, but restrictive heart failure, where you have significant diastolic heart failure, it's also common. Next. Diagnosis is easy, also non-invasive. You don't need to do a biopsy. It's with MRI. This is a non-contrast technique. We call it the T2 star, which usually it has a very high diagnostic accuracy. We can measure that. This time we measure it in an MRI based on a technique. Usually goes down significantly if you have a lot of iron deposition in the heart or even in the liver. We can measure it also in the liver. And usually when it's less than 20 milliseconds, has a very high diagnostic accuracy for involvement of that organ, for example, liver or heart, as I'm showing in the system. you can do quantitative analysis for that. And this is also important in gauging treatment response. So you want this time to go up as you treat hemochromatosis. All this non-invasive, non-contrast MRI, very high diagnostic accuracy and non-invasive technique. Next. So treatment for hemochromatosis is like, gelation therapy or blood transfusion or phlebotomy, sorry. The final one I'm going to talk about quickly is Fabry's disease. Fabry's disease is a not common X-linked disorder, but where a mutation happens in the GLA gene. Although it's X-linked, it can affect females. Usually, if it affects females, it affects them later in life, and it's a milder form of the disease. Clinical manifest, it causes hypertrophic cardiomyopathy and heart failure. But clinical manifestation that is distinct to it, you have this whorl-like corneal opacification, skin changes and angiokeratomas, you have renal disease, and it can cause CNS symptoms like neuropathy, strokes, and etc. In cardiac involvement, you can have hypertrophic cardiomyopathy or thickening. It's one of the differentials for that. On the blood test, you have low alpha galactosidase A. And when you do genetic testing, it's going to be positive for GLA gene mutation. MRI is diagnosis, as I said, echo and MRI. Echo shows hypertrophy. MRI shows distinct scar pattern that involve the infralateral wall. And treatment is enzyme replacement therapy. Next. So at the end, I want to conclude, you guys are the frontiers that we have in evaluating these patients. You can see all of these cardiomyopathies. They don't have a specific symptoms, just pathognomonic for them. They overlap. Most of the diagnosis is not biopsy driven. It's non-invasive diagnosis, and very, very, very important, treatment early on in any of these cardiomyopathies really help the patient prognostically and prevent future complications. So always keep it in your mind if you have patients with hypertrophic cardiomyopathies. Thank you very much. And thank you, Deborah, for having us.
Does anyone want to put any questions in the chat or unmute themselves for any questions? Dr. Makkiya, we just have a few minutes left. Besides the echocardiogram, is there any other suggestions? I know you had mentioned, some labs or a chest x-ray and things like that. Is there anything else that you would recommend prior to referring to the cardiology department for cardiomyopathies?
A very excellent question. Definitely. First of all, you should have the suspicion. I will highly hinge in any patients who have heart failure or you see diastolic heart failure with arrhythmia in their chart, have this differential diagnosis because any of these can be the etiology. Okay. Start with an EKG, start with the thorough history, basically, taking clinical symptoms, physical exam. Although it's not common, but you can see this macroglossia, you can pass by it, and that makes you more, oh, this is maybe more serious. This is maybe, and this guy's anemic. I'm looking at his CBC, his hemoglobin is low. This may be a multiple myeloma with AL. Okay. Then start with an EKG, see the EKG is like LVH or there is some issue with the EKG. Definitely do an echocardiogram. And if your echocardiogram is suggestive of heart failure, at that time, I would send it you can send, I usually start with an MRI, which is detailed, as I said, and then take it from there, but send it to a cardiologist. Let them start, because, okay, this guy has heart failure, has arrhythmia, has symptoms concerning for sarcoid. They have lung sarcoid and they have heart failure. Send them to cardiology so we can do more detailed testing and start treatment early on them.
Thank you. Well, in closing, thank you so much, Luke and Dr. Makkiya, for that comprehensive presentation. Your expertise and leadership in the care of complex cardiomyopathy is amazing. I am honored to work in your group with you guys. You guys are really transforming lives. As Luke mentioned, I see these patients, and when we reach them early, we can see such a significant increase in their quality of life. So I'm really grateful for both of you for taking the helm at VCU in the HCM program.
Exactly. Very good. And we have therapies. We have therapies
Yeah.
that really can make a difference in slowing the progression of these conditions. You don't and now we are working on therapies to reverse these conditions, which can happen in the future. And you can protect life or can save life to prevent if they are like risk of having complications. All of these can cause sudden cardiac death and can kill these patients, even the young. And you can prevent that if you thoroughly investigate them and if you send them for a comprehensive center with the expertise anywhere. Basically, you can prevent and save life by doing so.
I mean, I've even seen it where we've done genetic testing on mothers, and then we brought in their sons, their children, in the children's department of VCU cardiology to start getting monitored. So I've seen it firsthand with genetic testing.
Exactly.
Yeah. As a reminder, if you're claiming the CME credit, please text 36733 to 804-625-4041 within the next 48 hours, and then complete the evaluation at vcu.com-cme.com in the next 30 days. But again, my email is easy. It's deborah.fora@vcuhealth.org. So if you guys have any questions in regards to that, I'm really easy to get a hold of via email. So looking ahead at our next session, it will be Wednesday, July 16th, 2025, and we'll be presenting Emily Holtz. She's a nurse practitioner in our electrophysiology department, and she's going to be doing a topic on palpitations, diagnosis, and management. I know we all see those types of patients. Thank you again for joining us tonight. Please continue to spread the word about the series with your colleagues and let us know what topics you'd like to see in the future. Have a great night, everyone. Thank you.
Good night, guys.
Thank you.
Thanks.